Good morning. Muriel Finkel here. It's 10 a.m. in Wooddale, Illinois, and the ASG welcomes you to our first virtual Amyloidosis Support Group meeting. I want to let everyone know that this program is being recorded for posterity. Because of COVID-19, we've had to postpone our spring meetings, and as of today, we're not sure how long that will be. Today's meeting is for our AL amyloidosis patients. AL is also known as light chain or primary amyloidosis. We will be having a virtual meeting next Saturday, the 25th, for our ATTR patients. Both wild type and hereditary will be covered then, along with our non-ATTR hereditary patients. First, I would like to tell you about the ASG people. They're acting as crew today and making this event possible. I'll ask them to wave and say hi when they hear their name. Our executive producer and director is Bob Gibson. Bob is in his control room in Virginia.
That's me over here. Hi, everybody.
He's the ASG Special Products Director, and he also helps us in every way possible. Then we have Paula Schmidt. She's our assistant producer. A lot of people know Paula.
Hey, everybody.
There you go. And Paula's our assistant producer and director today and is in her own control room in Albany, Georgia. Paula is the ASG executive director and facilitates about 24 meetings a year. Pat Gibson lives in Maryland and is our public policy liaison, but I don't think we can see her on the screen today. Tracy Deutsch lives in Indiana.
Hello.
And Tracy is our acting page today. She's the ASG international liaison as well as a facilitator. John Matheson lives in the Pacific Northwest. Wave, John.
Morning.
Okay. And John has taken over our Texas meetings from our now retired Liz and Mike Will. Also not able to be on the screen today are Kay Rowley from Washington State, Linda Lado from Pennsylvania, and Beth Martin from Indiana. Sitting next to me in our Illinois office is my husband, Stephen Finkel. Thank you, Steve. Okay, today we'll be showing you our amyloidosis awareness video. Both the video and the booklet can be downloaded on amyloidaware.com. We're in the process of updating both the booklet and the video, but even in their present form, they give a great overview of the disease. We encourage you to share the video and booklet with friends and family. After the video, you'll hear from Dr. Heather Landau from Memorial Sloan Kettering in New York City. Dr. Landau has been a guest at many of our meetings over the years and will be giving a presentation on AL amyloidosis treatments and trials. After Dr. Landau's presentation, you'll hear some updates on financial aid and resources from Paula Schmidt, who's our executive director. Paula, as you know, also facilitates about 24 meetings a year for the ASG. After an update on the amyloidosis registry from ASG's Bob Gibson, you'll hear a few words from the Amyloidosis Foundation, Amyloidosis Research Consortium, and Mackenzie's mission. We'll then take a 10-minute restroom, make a cup of coffee or tea break. And when we all return, you'll then hear from Dr. Rick Ruberg, cardiologist from Boston University's Amyloidosis Clinic, and another frequent guest at our meetings. Dr. Ruberg will help to explain what is going on with the amyloid heart. After our cardiac presentation, we'll hear from Michael Spector of the Calum Biosciences, who will be starting a new clinical trial with their antibody that will hopefully vacuum away amyloid fibrils from the organs. Following that, we'll hear from Dr. Jonathan Wall, scientist and researcher from the University of Tennessee, who's conducting an imaging study. Have you ever wondered what it would be like to see which organs would light up on a screen if they're infiltrated with amyloid? Dr. Wall will go into that in some detail. Then another quick break before our Q&A with our panel of experts. I do want to say a few words about how to ask questions for the Q&A. Zoom may be new to many of you, as it certainly was to me a few weeks ago. Many of you probably know this program better than me, but here goes. We want all of our attendees to ask questions of our wonderful panelists. For this webinar, the only way to ask questions is by typing them into the Q&A window, not chat. Chat will not work for your questions. It is enabled only so that we can share some links with you. Let me explain how to use the Q&A icon. I know Muriel explaining something technical, but here goes. First, find the Q&A icon on your screen. If you're viewing the webinar on a computer, you should see a Q&A icon at the bottom of the Zoom video screen. In that black bar that also has Leave Meeting on the right, but don't select Leave Meeting, just click on the Q&A icon. If you're on an iPhone or an iPad or an Android device, this Q&A icon might be harder to find. If it isn't in the bar at the top or bottom of your screen, look to see if there are 3 dots in one of those bars. Try tapping it. That window might open and it might have Q&A as an option. Otherwise, just try tapping on your screen to see if the Q&A icon appears. Once you're in the Q&A window, just type in your questions and hit send. There's an option to send anonymously if you want to. Otherwise, it will appear to everyone under the name you registered with. Remember, everyone's being recorded, so if your name gets repeated, people will hear your name. One last thing on questions. You can use the thumbs up icon to like a question someone has asked. So if you see one you really want to have answered, please give it a thumbs up. And to avoid duplication, if you see a question you wanted to ask, just give it a thumbs up rather than asking it again. We'll try to answer all the questions during the Q&A session. We're estimating that today's program will be over 3 p.m. Eastern, 2 p.m. Central, but that's just a guess. You now should be able to find that Q&A icon and ask away. On our panel today are Dr. Shakra Shalagan, Andrea Havasi, Shafiq Karam, Saji Kumar, Heather Landau, Jignesh Patel, Maria Picken, Kara Rosenbaum, Rick Ruberg, Vishali Sancharwala, Brett Sperry, Barry Trachtenberg, Jason Valent, Robert Vesio, David Walensky, and Jeffrey Zonder. We'll hear more about them later. Also hanging around to answer questions will be Dr. Jonathan Wall and Michael Spector from Calum. A few of us from the ASG are also here to help facilitate. We know that some of you might have to miss part or all of this meeting. Please know there will be a link given out to all, and that will allow playback of the meeting. This will also be posted on our website and Facebook group. It won't be sent right away, but you will get it as soon as we have it available. Okie dokie. More later. We've got Bob Gibson and Paula Schmidt in the control room now, so I'll ask them to play the video.
Amyloidosis awareness. Throughout our lifetime, our DNA codes for the production of small molecules called proteins. These proteins provide the structure and function for nearly all of life's biological processes. Once proteins are made in our cells, they naturally fold into a particular shape. This shape allows for their specific function in the body. When proteins are folded properly, they work as they should, and we enjoy good health. When proteins are misfolded, it can impair our body's normal functioning, and problems may arise over time. Our bodies are usually pretty good at identifying and removing abnormal proteins. In some cases, though, we either produce too much of the abnormal proteins for our bodies to handle, or we're not able to break down and clean up the proteins at all. Amyloidosis is just one class in a growing list of protein folding disorders. While there are many types of amyloidosis, in all cases, the misfolded proteins called amyloid, meaning starch-like, take on a particular shape that makes them very difficult to break down. Because of this misfolding, amyloid proteins bind together to form rigid, linear fibrils that ultimately build up in our tissues and organs. Depending on where the amyloid accumulates, such as in the kidneys, heart, nerves, or gastrointestinal tract, different symptoms become apparent as those organs are affected. Left untreated, amyloidosis is life-threatening. So early, accurate diagnosis is key in promoting positive outcomes. Currently, over 25 different proteins have been identified that can lead to amyloidosis. The many types of amyloidosis can be classified according to the precursor protein that is misfolding. A simple naming system is used, such that the prefix A refers to amyloid, followed by an abbreviation for the protein underlying the condition. In AL, or primary amyloidosis, the most commonly diagnosed form of the disease, the amyloid is derived from misfolded light chain antibodies. White blood cells in the bone marrow, called plasma cells, are producing too many defective light chain proteins. The kidneys, heart, liver, GI tract, and nerves are most often affected. In AA, or secondary amyloidosis, the disease results from increased levels of circulating serum amyloid A protein. The body produces this protein as a natural response to chronic infection or inflammation. The kidneys and liver are the main sites of amyloid deposition. In ATTR amyloidosis, the amyloid originates from the transthyretin protein, which is produced in the liver. In hereditary or familial forms of the disease, there are over 100 genetic mutations already discovered as contributing to amyloid formation, which primarily cause nerve damage and heart problems. A non-hereditary form of the disease, known as senile systemic amyloidosis, results from TTR amyloid building up in the hearts of the elderly. Whether caused by genetic factors or increasing age, TTR-mediated amyloidosis is actually thought to be more common than AL amyloidosis, though it often goes undiagnosed. Amyloid also sometimes deposits in isolated areas, such as the bladder or airways, without evidence of a systemic disease. These localized tumor-like deposits are made up of light chain proteins, similar to AL amyloidosis. In this case, the plasma cells producing the amyloid are in the affected tissues, not in the bone marrow. Many physicians will not expect to see amyloidosis in their clinical practice. Yet, for example, because TTR amyloid is often undiagnosed in patients with heart failure, it's very likely that the disease is much more prevalent than now recognized. The symptoms of amyloidosis are usually vague and non-specific, such as weight loss, fatigue, shortness of breath, foamy urine, swelling of the ankles and legs, and numbness or tingling in the hands and feet. Because these symptoms mimic those of other common conditions, often being mistaken for heart, lung, or kidney disease, it's not uncommon for a patient to see several physicians before a biopsy is taken. But if there is kidney, heart, nerve, gastrointestinal, or liver disease with no obvious cause, it should absolutely prompt physicians to test for amyloidosis. As part of the differential diagnosis, the 4 most common clinical settings in which amyloidosis should be considered are 1. Loss of massive amounts of protein in the urine. 2. Stiff or thickened heart. Low voltage on electrocardiogram, irregular heartbeat with normal or low blood pressure, or unexplained heart failure. 3. Enlarged liver without alcohol consumption or other explanation, often with abnormal liver blood tests. And 4. Numbness or pain in the fingers or toes, such as carpal tunnel syndrome, or alternating bouts of constipation and diarrhea, while also feeling lightheaded when standing up. The gold standard for detecting amyloid deposits is to employ Congo red staining on a tissue sample. The easiest way to get a sample is to aspirate fat from the abdomen, like a mini liposuction. Amyloid has a pink color when dyed with Congo red, and a characteristic apple green birefringence when viewed with a polarizing microscope. This signature technique is able to diagnose amyloidosis in 70 to 80% of cases. If the fat pad aspirate is negative for amyloidosis, but suspicion of the disease is high, a direct biopsy of the involved organ, for example the heart, kidney, or liver, should be done. If amyloid is present, the use of Congo red staining will yield a definitive diagnosis in nearly 100% of cases. Viewing the tissue sample with an electron microscope will also show the classic structure of amyloid fibrils, thus confirming its presence. Proving that amyloid is present in an organ is only the beginning of the process. Next, the type of amyloid causing the disease must be determined in order to plan for an appropriate individualized treatment. Recent advances in the field of proteomics promise to revolutionize the precise diagnosis of amyloidosis. Laser microdissection of Congo red positive samples, followed by mass spectrometry, is the premier technique in typing amyloidosis. LMD-MS can be performed on any tissue sample, including a fat pad aspirate, if amyloid is present. Studies have shown that LMD-MS can identify all known amyloid proteins with virtually 100% accuracy, as well as characterize new ones. All in all, with the possible exception of an enlarged tongue or bruising around the eyes, which are seen in a small percentage of cases, there are no telltale clinical signs of amyloidosis. However, regardless of a patient's symptoms, because of the unique staining and spectroscopic properties of amyloid proteins, it is a simple matter to test for the disease. Early and precise diagnosis is essential for patients to benefit from the many treatments now available. Depending on the type of amyloidosis, treatments may include chemotherapy, cardiac care, organ transplantation, or targeted drug therapy. In each case, the aim is to reduce or eliminate the supply of amyloid protein so that organ function can improve. There are 3 general approaches to disrupt the formation and deposition of amyloid, which vary according to the type of amyloidosis. The most common treatment interferes with the production of the precursor protein, leading to the disease. The second method uses drug therapy to stabilize the normal structure of the precursor protein, thus preventing it from misfolding into amyloid. The third strategy targets the amyloid directly, both circulating in the blood and deposited as fibrils in the tissues. By tagging and destabilizing the amyloid, one's body can potentially identify and remove the abnormal proteins more effectively. Given the complexity of the disease and that each case is different, it is recommended that treatment be performed in a medical center which has experience with amyloidosis. Alternatively, patients can have an initial evaluation at such a center with continued communication during treatment in his or her local community. For a free illustrated booklet that explains amyloidosis in more depth, please visit amyloidaware.com.